Sundeep Mishra.
Thank you, Chairman Sir, and I have to thank Bangladesh Cardiac Society and Dr. Mohsin and Dr. Mazumdar for calling me here, and I would like to make my presentation. So let me share my screen. So are you able to see my screen? Are you able to see my screen?
Yes.
Okay.
That's able to see.
Yeah, thank you so much. So what I'm going to do today is to present this topic, hypertension in chronic kidney disease. Okay, so we know that hypertension is the most common heart disease. Interestingly, 85 to 95% of chronic kidney disease patients have hypertension. We also know that uncontrolled hypertension is a risk factor for developing chronic kidney disease and is also associated with more rapid progression of CKD and is second leading cause of end-stage renal disease after diabetes mellitus. Hypertension with decreased GFR, patients of hypertension with decreased GFR are also at increased risk for developing cardiovascular disease more than they are at risk for developing end-stage renal disease. So patients with high blood pressure are also high risk of developing renal impairment and cardiovascular complications. Interestingly, there is a benefit of treating these kind of patients for hypertension and as well as for the kidney disease. Now, coming to the chronic kidney disease, it is generally defined as persistent kidney damage, reduced GFR, and albuminuria affecting 1 in 8 adults. So it's a relatively common condition, though it may not be recognized in that manner. CKD also contributes to global burden of morbidity and mortality as well as cardiovascular events. So interestingly, the point that I'm trying to make is that while patients have hypertension and CKD, the most common cause for their ailment may be developing cardiovascular disease. So it's always important to decrease the risk of cardiovascular disease in these patients. Also, another important factor is that not only decreased GFR, but albuminuria itself is also predictive of increased risk of coronary artery disease. Now, the question that may be asked is whether the hypertension causes the chronic kidney disease or chronic kidney disease can cause hypertension. So we know that hypertension has many deleterious effects, including effect on kidney vasculature. But more than kidney vasculature, what uncontrolled hypertension can do is increased intraglomerular pressure, and which leads to decreased filtration and damage to glomeruli and more protein production in the urine. And then, you know, there are two types of protein production: microalbuminuria, when protein to creatinine ratio is less than 200 milligram per gram, or frank proteinuria, when it is more than 200 milligram per gram. And in fact, frank proteinuria is associated with poor prognosis for both kidney disease and cardiovascular disease. But not only hypertension can cause chronic kidney disease, interestingly, chronic kidney disease can also cause hypertension per se. And the reason is that once chronic kidney disease happens, there is affection of the afferent signaling pathway, which leads to a more potentiation of the renal efferent sympathetic pathway, and which leads to increased sympathetic drive, which can lead to hypertension. Furthermore, there can also be volume expansion. So there are two mechanisms for increase in blood pressure in a chronic kidney disease. One is increased sympathetic activation, and the second is volume expansion. So basically, in reality, what happens is that there is a vicious cycle. Any of them happening, whether it is CKD or hypertension, will ultimately contribute to damage of blood vessels within the kidney and affect the kidney's function to filter fluid and waste, and therefore cause not only more kidney damage, but also increased blood pressure. So basically, it's a vicious cycle once it gets started. Now, how to evaluate a patient, this kind of patient with hypertension and chronic kidney disease? The screening tools for CKD are, you have to measure serum creatinine and estimate GFR. That is very important, and I will discuss why it is very important, and it has prognostic implications as well. Also do urine analysis to look for leukocytes and dysmorphic red blood cells and casts, and calculate urine albumin to creatinine ratio, or UACR, which we will discuss. Do renal ultrasound, and I think all of these things are important because I will just discuss with you. On the other hand, how to evaluate blood pressure? I think we know that it is important to measure all three types of blood pressure: office blood pressure, the home blood pressure, and ambulatory blood pressure monitoring, because that will give us the complete picture of type of hypertension. Also, we have to rule out the secondary causes of hypertension, which could be endocrine, renal parenchymal disease, renal artery stenosis, non-specific aortoarteritis is still prevalent in this part of the world, and of course, diabetes mellitus. Now, what I will do is, rather than talking about, theoretically, what I will do is present some case scenarios to you, and then discuss how we physicians can tackle those situations. About 5 types of situations can happen in this particular patient of CKD with hypertension. One is a diabetic patient with CKD hypertension. The other is CKD hypertension patients with proteinuria. The third kind of patient is CKD hypertension without proteinuria. Then the fourth variety is end-stage renal disease with hypertension presenting with metabolic acidosis. And finally, both CKD and resistant hypertension. So what I will do is I will do 4 cases. First one will combine the first two, which is CKD, hypertension, diabetes, and proteinuria. The other one will be CKD hypertension without proteinuria, and then that with metabolic acidosis, and then finally of resistant hypertension with end-stage renal disease. So coming to the first patient, diabetic CKD with hypertension and proteinuria. So here is this 68-year-old lady who had diabetes mellitus for long, metformin and sulfonylurea with HbA1c 7.6, hypertension, despite being on hydrochlorothiazide of 160/90. She also had osteoarthritis, was on celecoxib, and creatinine of 1.1, eGFR of 55 ml, and UACR of 550 milligram per gram. So basically, and you can see on the right side is a X-ray, which does not show any cardiomegaly, and ECG also seems relatively normal, except that there is some tachycardia. So the diagnosis is type 2 diabetes mellitus with hypertension. With also she had past history of CAD, but is present no CAD, CKD, but no manifest heart failure. Now we took her for echo, and all valves were normal. Left ventricular ejection fraction was also normal with no present wall motion abnormality, no diastolic dysfunction, no pericardial effusion. So is everything okay? I think it is important to realize that in diabetics and with kidney disease and hypertension, we have to look for early signs of heart failure. And what are those? One is the decreased global longitudinal strain, even with normal ejection fraction, because that independently correlates with the some of the diabetic parameters. And also, dobutamine infusion, dobutamine stress echo can induce LV dysfunction even in the absence of coronary artery disease or vasospasm. So I think these 2 things we should look for in every echo to look for the early signs of heart failure if present, because this patient can be a risk for heart failure. Now, the first question that I'm going to ask is, does this patient have CKD? We saw that her creatinine was about 1.1. Now, in any patient who has GFR less than 60 for more than 3 months, we call significant kidney damage or CKD. And actually, there is a classification of CKD, and that is on the right side. where despite kidney damage, the GFR may be more than 90. That is the stage 1. When it is between 60 to 90, it's stage 2. 30 to 59, stage 3. 15 to 29, stage 4. And kidney failure when it is less than 15 or patient is on dialysis. Furthermore, the other classification is also very important because albumin, urine albumin is a very important parameter, and the albumin creatinine ratio, if it is less than 30, may be considered normal, but between 30 to 300 is moderately increased, and more than 300 it is severely increased. So in our patient, where does our patient belong? We saw that eGFR was 57, so type stage 3 kidney disease, CKD, and also we saw that albumin by creatinine ratio was 500, more than 500, so it is severely increased. Why is this kind of classification important? Because it is very important to prognosticate the cardiovascular mortality. And so you can see that our patient belongs to here, lies here, which is G3 and A3. So G3, A3, and you can see that there is 4-fold increased cardiovascular mortality in this patient. Therefore, this classification is very important in each and every patient of CKD and hypertension, so that we can predict how much patient is due for morbidity or mortality. And what are the issues in this patient that I already discussed? The number one is that, as I already discussed, that these patients are at increased risk for cardiovascular events, MI, stroke, or peripheral vascular disease. Even more than that, this patient is more than 4 times increased risk for heart failure. And actually, the HbA1c level is associated with increased incidence of heart failure. So that is number one. This patient is at increased risk for coronary artery disease and heart failure. But the other thing is that I wanted to discuss with you is the possible growth progression of CKD in this patient. And as a matter of fact, there are many things that we can do to control the progression of CKD. And effective blood pressure control is number one. Use of renin-angiotensin inhibitors is number 2. Good glycemic control is number 3. And then use of SGLT2 inhibitors or GLP-1 receptor agonists is number 4. Then finally, if the patient has metabolic acidosis, then that control of metabolic acidosis is another very important thing. Dietary protein restriction is another one. Weight loss, even bariatric surgery if there is a lot of obesity. Sorry? Hello? Can you hear me?
Yes, sir. Yes, sir.
Can you hear me? Okay.
Yes, sir. We are having you.
And then if anemia is, okay, all right. If anemia is present, control of anemia is another way to slow the progression of CKD. So once the patient has CKD, all is not lost, but can do a lot of things to actually prevent the further progression of CKD and prolong life and decrease morbidity as well. Now coming to the blood pressure, we see that of the end-stage renal disease, both in men and women, and severe hypertension is correlative of more risk of developing end-stage renal disease, which means that if you can bring down the blood pressure effectively and bring it to normal or optimal blood pressure, you can see that the risk of progression to end-stage renal disease is actually nullified. It becomes nearly zero. The other thing is that use of ACE inhibitors or ARBs, actually number of trials, as you can see, that use of ACE inhibitor or ARBs can also, compared to placebo, slow the progression of CKD. So that is another good strategy, especially in those patients who have proteinuria. And I will talk about it later. The third thing is that a good glycemic control can not only reduce the progression of CKD, but also decrease the incidence of proteinuria. So what is the level of the glycemic control to be achieved? The guidelines suggest that if patient has got no comorbidities, or is not at risk for developing hypoglycemia, then HbA1c level of 7 is very good. On the other hand, if patient is at risk for developing hypoglycemia, and this could be advanced age, presence of vascular disease, already severe CKD, or multiple comorbidities, then HbA1c level of about 8 can be acceptable. Regarding metabolic acidosis, there are multiple reasons through which metabolic acidosis can happen. And basically, the one reason is that the amount of the kidney size, parenchyma available to filter is decreased in chronic kidney disease. So naturally, it cannot pass on the acid into urine, and therefore the slow acidosis keeps developing. The other thing is that there could be disease of tubular interstitial disease or disease of collecting tubules, where the maximum amount of acid secretion happens. And once there is this disease or interstitial fibrosis of collecting ducts, then there could be a lot of metabolic acidosis, which can also be very progressive. So now coming back to our patient, what can we do? Number one, we can of course change lifestyle, regular exercise, maintain a healthy weight. Remember, decreasing weight can retard progression to chronic kidney disease. A well-balanced diet and control blood sugar levels. Also, achieving a good glycemic control, as I already discussed, can reduce the progression of CKD. So now, what is the target of blood pressure control? It depends on the albumin creatinine ratio. If it is normal, then maybe a higher blood pressure can be acceptable. But if it is between 30 to 300, or if there is more than 300, then a very tight blood pressure control of less than 130 by 80 should be ideal. But always it is important to individualize the targets. Now, why do we want to achieve this tight control of blood pressure? Important thing is that it not only decreases the tight control of blood pressure, not only decreases cardiovascular morbidity and mortality, but also decreases the renal disease or progression of renal disease. That is why a tight blood pressure control in this kind of patient is very important. Now, coming to what kind of anti-diabetics to use, of course, metformin is always the drug of first choice, but in these kind of patients, SGLT2 inhibitors can be very useful, because not only they decrease glycosuria and decrease some blood pressure, but they also not only reduce the cardiovascular events and heart failure hospitalization, but can even reduce proteinuria and thus progression of CKD. Only problem is that they are weak glucose lowering agents, decrease HbA1c by only about 0.5%, and also they are costly. Similarly, GLP-1 antagonists can also not only decrease the cardiovascular events, but also decrease the risk of CKD. So these two agents, SGLT2 inhibitors and GLP-1 receptor agonists, may be a very good idea in this kind of patients, because they can reduce not only the cardiovascular risk, but also the progression of kidney disease. However, it is better to avoid these, because they can increase the risk of heart failure. And also other DPP-4 inhibitors of sulfonylureas and insulin, and DPP-4 inhibitors and sulfonylureas, there is some controversy with DPP-4 inhibitors, and they can be used in certain situations, but these thiazolidines and sulfonylureas are not a very good idea in this kind of patient. Insulin has to, if we have to achieve a good glycemic control, otherwise, I think second choice in these kind of patients should be SGLT2 inhibitors or GLP-1 receptor agonists, as the case be. If the patient is obese, then actually SGLT2 inhibitors are more useful. Now, coming to antihypertensive, what kind of antihypertensive agent to use? And I have prepared this. You can see that depending on the type of scenario the patient is presenting, the antihypertensive should be chosen. If it is a diabetic CKD patient with hypertension, then ACE inhibitor or ARBs are the first choice. Likewise, if there is a lot of proteinuria, again ACE inhibitors or ARBs are first choice, because these ACE inhibitors and ARBs are known to reduce proteinuria. But if there is no proteinuria or there is microalbuminuria only, then any agent may be preferred. But if there is a fluid overload, then diuretic becomes the drug of first choice. So coming back to our patients, what kind of antihypertensive to use? So our patient is actually diabetic, CKD, hypertension with proteinuria. So I think it is very clear that renin-angiotensin inhibitors are the drugs of first choice. ACE inhibitors or ARBs, here is more data with ACE inhibitors, and actually ACE inhibitors are known to reduce 10% mortality, which ARBs are not known to reduce. So maybe ACE inhibitors should be preferred over ARBs. However, if there is fluid overload, then thiazides should be used, or diuretics should be used, or combined with the ACE inhibitors or ARBs. Which one to use? Thiazides are generally used when there is stage 1 to 3 kidney disease, CKD, stage 1 to 3 CKD, then use thiazides. But if it is stage 4 or 5, use loop diuretics. The third agent that should be considered is non-dihydropyridine type of calcium channel blockers, that is diltiazem or verapamil. Why diltiazem or verapamil? Because these agents are also known to reduce proteinuria. So wherever there is proteinuria or wherever there is diabetes, there is a higher likelihood of proteinuria, then diltiazem or verapamil should be preferred over other calcium channel blockers. And finally, MRA may be considered the mineralocorticoid receptor antagonists like spironolactone or eplerenone may be used if there is no hyperkalemia despite giving renin-angiotensin inhibitors. As I already discussed with you, ACE inhibitors or ARBs are useful whenever there is proteinuria. However, one caveat, don't combine ACE inhibitors or ARBs, because combination can lead to rapid progression of renal disease and hyperkalemia and rapid development of end-stage renal disease. So use one of them, preferably ACE inhibitors, but don't combine both of them. The other things that can be done in this patient is a low salt diet, which can help, and I already discussed that a low salt diet can augment the effects of ACE inhibitors or ARBs, not only in controlling blood pressure, but also in controlling proteinuria. So a low salt diet is a good idea. Diuretics may be necessary when there is volume overload. I already discussed thiazides are more effective in grade 1 to 3 chronic kidney disease, whereas loop diuretics are more useful in grade 4 chronic kidney disease. And then coming to calcium channel blockers, diltiazem and verapamil are more useful because they can cause proteinuria reduction. Now, also I already discussed with you that SGLT2 receptors inhibitors are the best for this kind of patient of diabetes and hypertension and chronic kidney disease. And the results show that there is a across the board reduction, whether it is a combined outcome of dialysis, transplantation, or death, about 1/3 reduction in relative risk, or end-stage chronic kidney disease, again 1/3 reduction, and or any other parameter, even acute kidney disease, about 1/4 relative risk reduction. So it's a very good idea to use this particular agent. So what we did in our patient, we added ramipril to achieve a blood pressure of less than 130/80. We also added empagliflozin, 25 milligram added. 1 month later, her creatinine was 1.4. Baseline, as you might remember, was 1.1. So now what to do? I think at this point it is very important to understand. Sorry? So it is very important to...
Please continue. Sir, we are running short of time, so please continue, sir.
Okay. Very important to understand that if there is more than 25% elevation of creatinine, then after initiation of ACE inhibitor, we should not stop the ACE inhibitor, but reduce its dose and check creatinine values again, stop NSAIDs if present, and even can use potassium chelating agents. Why? Because renin-angiotensin inhibitors have significant cardiovascular protective effects. So now I come to my another case, which this patient who was taken lot of NSAIDs, and because of that she developed chronic kidney disease and also developed anemia, and patient was already hypertensive, and this is the result you can see. Now, which is the best agent in this patient? Now, as I already discussed, because there is no significant urine albumin, no protein urea, so best thing is to use a diuretic, and that is the best choice. But then if other than that, you could even use dihydro, you can also use amlodipine or nifedipine type of antihypertensive in this kind of patient. If for anemia, I think it is important, there can be many mechanisms of anemia. First thing to do is to look for iron deficiency, and if iron deficiency is present, then IV iron is the best treatment, and the target is to achieve the hemoglobin value of 9 to 11.5. So I think that is the thing. Now coming to our patient of end-stage renal disease with metabolic acidosis. Now this is a patient of 58-year-old male, thalassemia, hepatitis, hypertensive, stage 4 kidney disease, and long-term kidney dysfunction over 13 years. And as you can see on the right side, patient developed metabolic acidosis, low eGFR less than 30, and a pH of 6, and soda bicarb of 19, so less than 20. Now, how do we intervene in this patient? Now, it is very important to understand that if soda bicarb level should be kept, bicarbonate level should be kept 22 or more. If it is less, then it is important to treat. And the way to treat is give 1300 milligram BD of soda bicarb, and then follow up the patient. So this is what we did. And there can be two reasons I already discussed with you. One is decreased kidney volume that causes filtration and therefore development of acidosis. But even more, if there is a damage to collecting duct, which happened in this case because of thalassemia, then the pH may decrease even less than 7, and that is what happened. And as I already discussed with you, bicarbonate level of more less than 22 is associated with progression of kidney disease. Therefore, it is important to maintain this level of more than 22 by giving soda bicarb. And that is what exactly we did in this patient, and we were successful. Finally, coming to my last case, this is a patient diabetic with uremia on hemodialysis, but had hypertension which was resistant to 7 drugs. ARBs were giving telmisartan, calcium channel blockers, metoprolol, dihydrolazine, torsemide, moxonidine, and even prazosin. Still, blood pressure was 180 to 210 by 90, and stage 5 kidney disease. So what do we do? Should we stop renin-angiotensin inhibitors? Again, renin-angiotensin inhibitors not only reduce the risk of cardiovascular events, but even kidney events. Therefore, if there is no hyperkalemia, they can be continued. And if some hyperkalemia developed, then even we can give potassium chelating agents. So I think it's important, if as far as possible, to try to reduce, but if it is not possible, then we have to stop renin-angiotensin inhibitors. In this particular patient, 7 drugs were tried, but no blood pressure control was achieved. So in our lab, we still had those catheters. So we did renal denervation therapy, and on by day 4th, blood pressure had come down, and the doses of antihypertensive was also reduced. Later on, 1 year later, on an ambulatory blood pressure monitoring, you can see that blood pressure had become normal. So finally, I would like to conclude by saying that progression of kidney disease can be delayed by treating hypertension, by achieving good control of blood pressure less than 130 by 80, using ACE inhibitors or ARBs, improving diabetic control, correcting metabolic acidosis if it is there, treating anemia, using low protein diet, even statins, smoking cessation, and vitamin D supplementation where necessary. Among the antihypertensives, use of ACE inhibitor or ARBs is useful because they can reduce proteinuria. Better to use ACE over ARB. Diltiazem and verapamil can also reduce proteinuria, and therefore useful in those kind of patients. However, if there is a lot of volume overload, then diuretics are preferable. Thiazides, if it is grade 1 to 3 kidney disease, but loop diuretics if it is more than grade 4 or more kidney disease. Rationale for decreasing blood pressure is not only to decrease cardiovascular events, but also to decrease progression of kidney disease. Among the anti-diabetic drugs, SGLT2 inhibitors and GLP-1 agonists are very useful because they are not only cardioprotective, but also renoprotective and decrease the progression of renal disease. Likewise, treating anemia when present is a good idea, maintaining a target of 9 to 11.5 gram. Whenever creatinine increase after use of renin-angiotensin system, important to look for potassium levels, and if they are okay, then maybe reduce the dose of ACE inhibitors and ARB, but don't discontinue as long as possible, but avoid nephrotoxic drugs like NSAIDs. So I think that is an important point. Finally, metabolic acidosis is a common complication, can occur in about half of the patients who have 4 or 5 stage kidney disease. 2 reasons I already discussed with you. Important to manage bicarbonate level of more than 22, which can be achieved by giving even thrice bicarbonate therapy. And if patient is resistant to hypertension, we might require novel therapies like renal denervation therapy. Thank you so much for your kind attention.
Thank you very much, Professor Dr. Sundeep Mishra sir, for his masterpiece, wonderful and A to Z lectures on hypertension in CKD. Now we will go directly to the speaker of session 3, Dr. David Quack, because he is running short of time and he has back-to-back lecture. After his lecture, we are going back to the discussion on session 2. Thank you very much.